Hello everyone, good morning. Okay, so yes, we are here live on LinkedIn and for the first time ever on YouTube as well. I'm so excited to be here, and this is the first time I'm holding this session during the working hours. So this is great, and today I will be talking about joint replacement, starting with hip replacement and then knee and ankle. And yes, so I'm going to start soon. I'm just waiting for more people to join us. And then we'll be talking all things joint replacement for about 30 minutes. I try not to go over 30 minutes, but at the same time, I have a lot to share. So we'll see how it goes. But yes, expect just over 30 minutes. I'm going to start now, and let's have a look. Okay. So yes, this is an introduction to hip, knee, and ankle replacement. So a little bit about me. My name is Shamsad, and I am a biomedical engineer. I have experience working with orthopedic implants as a bioengineer in with NHS implant service, where we looked at used and failed implants. And at the Synthese of Johnson and Johnson, I worked with and used brand new implants and design and development and maintaining them on the market. Currently, I'm doing my PhD at the University of Edinburgh on the same topic. And yes, so that's a little bit about me. And just to quickly remind you, this is our session for June, which I'm going to be talking about hip, knee, ankle replacement. But then I have another session scheduled for July. It's actually not published yet, so I will publish that soon. That on the 3rd of July, we will be talking about an introduction to shoulder and elbow replacement with a little section about wrist replacement and also finger joint replacement. So that's very exciting as well. If you're interested, please add that to your diary. And yes, so today for the first time, I am going live on YouTube as well. Previously, this was done on LinkedIn and Instagram. Now I'm testing YouTube to see what that is like. Moving on. Okay, an introduction to hip replacement. So today I'll be touching on a few things about hip prosthesis. And unfortunately, it is impossible to cover everything in this short live session. But if you have any questions about hip replacements and devices, feel free to comment below or drop me a LinkedIn message and I'll get back to you as soon as I can. Okay, so what I'm trying to show you here is the components that um, we have when we say hip replacement. There are four components usually. At the top, we have the acetabular cup, and then we have the acetabular liner, which is the plastic component, and then we have femoral head and the femoral component. I will tell you a little bit more about each component later during this session. So here's just one example to show you quickly the 0 to 100 of a hip arthroplasty or replacement. In this example here, hip replacement is performed using the direct anterior approach. Now, there are um, other approaches, as you can see here, all having their own pros and cons. And yes, so, but in this particular example, this is anterior approach and a 9 to 10 centimeter incision, as you can see dashed line on this picture right here. Now, inside the acetabulum, the worn out cartilage is scraped and reamed out to make way for the new cup. This device you can see right here is a reamer, and this is what it looks like in real life, with individual sharp round blades that act like a grater and remove the worn out cartilage in acetabulum. Now moving on, we have this right there. So orthopedic surgeons use x-rays to ensure that the cup is appropriately sized and placed in an optimal position, considering adequate inclination and anteversion. And if I want to show you what that means, it is a 3D concept, and using an image like this is not ideal, but basically inclination is the angle from the horizontal line right there, and anteversion is like rotation around this line. And that's very important for alignment of the artificial hip joint. Next, we have this component, which is a broach or a trial stem with sharp edges. And this is what it looks like. What it does is making space for the actual femoral stem. Using this instrument, the surgeon ensures the femoral stem is sized appropriately and is positioned inside proximal femur for the patient correctly. So this picture to the right is the actual stem, and this is just a broach to make space for the stem. And then we have this image right there. So once the surgeon is satisfied with the positioning of the trial implants, then the actual implants go in, as you can see on the x-ray. And yes, so this also ensures the surgeon that there are no fractures around the hip that is implanted, and that the implants are well sized and positioned for the patient. And here we have, yes, so this is what we call a bilateral hip replacement, this image right there, because the patient had joint replacement done on both hip joints. So that is a term that they use, bilateral joint replacement. Moving on. Now, why do we specify total hip replacement every single time? Now, this is just to be clear what we are talking about, as there are different types of hip replacements, some of them shown in this picture here. So top left, we have the native hip joint. This is a natural hip joint pre-replacement. And remember that the first time a patient receives a hip implant to replace their native hip joint, the procedure is called primary hip replacement. And if for any reason the implants fail and a second surgery is required on the same hip, it will be called a revision hip replacement. Now, next on the list, we have what is called hemiarthroplasty. So these two pictures right there, we have unipolar hemiarthroplasty and bipolar hemiarthroplasty. So when we refer to unipolar and bipolar, we're talking about the head of the component. So with unipolar, you have a head that is attached to the taper on the stem. So that's pretty easy. When we say bipolar, there's the head that is attached to the taper. However, there's a bigger bipolar head that sits on the first head. So in a sense, that provides more range of motion. Yes, and this applies to not only hemiarthroplasty, but also total hip replacement. So I'll explain what the difference is now. So a hemiarthroplasty is a surgical procedure that replaces the head of the femur. It's also known as a partial hip replacement, and it is used mostly to treat hip fractures, especially if the break is in the neck of the femur, right? So this one doesn't include a component that goes in acetabulum, right? So that's why it's partial hip replacement or hemi. If you compare this image to this one, which is a total hip replacement, you can see there is a metal component that directly sits or fixates into the acetabulum. Okay, well, we are here right now. Next, we have hip resurfacing. Hip resurfacing is a type of hip replacement surgery where instead of completely removing the femoral head, the damaged surface of the femoral head is trimmed and capped with a metal covering, while also reshaping the hip socket with a metal liner, essentially resurfacing the joint instead of fully replacing it. This procedure is typically used for younger, active patients with hip arthritis who want to preserve as much bone as possible and potentially maintain a higher activity level after surgery. For example, in January of 2019, tennis player Andy Murray underwent hip resurfacing surgery to address the hip pain he had experienced for a number of years. And then there is total hip arthroplasty or replacement, which is the focus of this session, of this section of my presentation today. And last but not least, right there to the right-hand side, we can see total hip arthroplasty with a constraint liner. Now, this refers to a special type of liner. I will show you the image again in a moment. That is used in total hip arthroplasty surgery that is designed to provide extra stability by tightly holding the femoral head within the socket. And it is primarily used in cases where a patient has a high risk of hip dislocation due to weak muscles or other factors causing instability. Now, if you look at this picture right there, there are two different designs of a constrained liner, just as an example. But essentially, it acts as a locking mechanism to prevent the femoral head from dislocating from the socket using these metal rings. Okay. Moving on to the next slide, and I think I'm going to remove my face from this presentation now because we need to see this bigger. Okay, maximizing the page. Okay, perfect. So here what we have is summary of key facts about joint replacement. This is based on the most recent National Joint Registry. So that was published in 2024, but it contains the data for the year before, so 2023. So in that year, there was 108,000 primary replacement procedures. Now, if you remember, primary is when a hip implant is inserted into native hip joint. So for the first time, the patient is getting a hip replacement. And the average age of patients, male patients were 67, just over 67 years old, and females just under 70 years old. And 60% of all patients were females. Now, next you can see 2% acute trauma. Now, that's showing us the reason that the patients underwent primary hip replacement. So why did they need a hip replacement in the first place? So 2% of all patients experience acute hip trauma, and that refers to a sudden significant injury to the hip joint, especially caused by a direct impact like a fall, car accident, or sports collision, resulting in damage to the bones, ligaments, tendons, or cartilage within the hip area, essentially a fresh hip injury that occurs rapidly and is not due to long-term wear and tear. And right next to that, we have 92% osteoarthritis, which is a chronic condition that causes joint pain, stiffness, and swelling. It is the most common type of arthritis, affecting the cartilage and bones in joints. And then the last item is average BMI 28.7. That is body mass index, and that number would fall into overweight section of the BMI chart. What I have next is basically here, hip revision. So at some point, the primary hip replacement might fail after so many years. So these are the revision reasons. So the reasons that the primary hip replacement didn't function any longer and they needed to be replaced. Now this second surgery would be called a revision hip replacement. And if we focus on the first three, the top three reasons, we have aseptic loosening. So that is when, as you can see in the picture, the bonding between the bone and the implant is not strong, so it starts to detach the implant from the bone tissue, and that is called loosening. And why is it called aseptic loosening? Because there is no infection involved, because infection, as you can see down here, can have a similar impact of making the component unstable. So in a sense, when there is no infection, but the attachment is also not there between the bone and implant, it is called aseptic loosening. And right now, it is the top reason for failure of primary hip replacement. Next, we have dislocation and subluxation. So dislocation is pretty obvious when the head of femur, or femoral component, is dislocated from the acetabular cup, or as you can see in this picture right here. And when this is almost dislocated, but not fully dislocated, that is when they call it subluxation. So it is kind of partial dislocation of the hip joint. And that is the second reason for revision. And third, we have periprosthetic fracture. Now, this is the area I'm currently working on, and it is really interesting. If you look at the pictures, it's obvious that periprosthetic fracture is referring to the fracture of the bone surrounding the implant. So the fracture there are different categories for the fractures, the ones you can see in the picture right here. On the left, you have fracture type A. That is just the top area of the femur is fractured, it's not impacting the component, and so that's type A. In the middle, we have type B1. So it's impacting the area that has the potential to affect the stability of the implant. However, in the picture in the middle, you can see that the implant is stable. So that's called B1. And at B2, it's similar to B1. However, the implant is no longer stable. If you pay attention to this area, you can see that the implant has moved from its position right there. And that's why it's no longer secure and stable. So that is periprosthetic fractures. Now about joint articulating surface material combination choices. You can see some on the top. At the top, we have metal on polyethylene to the left, metal on metal, which is almost retired now, and ceramic on ceramic. And each have their own pros and cons. Femoral head material and acetabular component material give you this mix of metal on polyethylene, metal on metal. That's referring to the material of the head and the material of the next surface that the head is articulating against. It can be plastic spacer or liner, or it can be the metal shell, as you can see in the pictures here. But we also have this for the head material. So from A to D, what we have right there at the top is pure alumina, and then zirconia toughened alumina, another ceramic, and pure zirconia and oxidized zirconium. Okay, these are other materials for the femoral head. Now at the bottom we have all the stems right here with different designs, materials like titanium alloy, cobalt chrome alloy, stainless steel, and the reason for different shades of the body of the stem you can see right here is because of different coating options as well. Another thing is modularity. So the femoral component can be modular, like the ones you can see here, or this one. So basically, if the head can be separated from the stem, that is modular. In some cases, the neck of the stem and the taper also separates from the stem body. That is also modular. And the other design is monoblock, where the whole head, neck, body is the same component. And that's called a monoblock system. Okay, now before we head to the next section and talk about knee joints, I wanted to highlight that if you're interested in the topic of hip replacements, want to know more about components, designs, materials, coatings, and all things hip replacement, feel free to take a look at my book called We Tips on Knees and Hips, which is available to order on Amazon. Now, are you still with me? Are you enjoying this session? Let me know. Give me a thumbs up or leave a comment, just so I know that you're still here. Okay, next we have an introduction to knee replacement. Okay, so here on the screen you can see names of the bones involved in knee surgery. So we have thigh bone at the top or femur, and shin bone at the bottom or tibia, and at the back you have fibula, the thinner bone, and then we have patella or kneecap on the right hand side, as you can see in the picture. A knee replacement surgery or arthroplasty involves replacing a damaged, worn, or diseased knee with an artificial joint. And about the components, here are the components of knee replacement. So we have femoral component at the top, we have plastic spacer, or better known as polyethylene insert, and the tibial component at the bottom. Now, one of the important topics in knee implants is the mechanics that enable the artificial joint to move and allow flexion and extension. Here you can see the main two construct concepts, which is fixed bearing option and mobile bearing system as well. Most knee prostheses on the market right now are either fixed bearing or mobile bearing. Basically, in a knee replacement system, a fixed bearing means that the polyethylene insert on the tibia is fixed to the metal tibial tray. It is basically clicked in. As you can see, there's a raised edge around this component right there, and this component clicks onto the tibial tray. While mobile bearing allows this insert to move slightly within the tray, mimicking the natural rotation of the knee joint. So here, this surface is smooth and there are no edges, nothing to click on. So this component with the little part that is down here sits inside tibial insert and is able to move slightly and rotate. So if we look at, so native knee motion analysis, which I'm going to show you right there, is a topic for another day, but just so you know, knee mechanics is complex and its movement involves rotation, pivot, and gliding motions, right? So it's a very complex joint with complex motion. And as such, a mobile bearing system was developed to allow the plastic insert to move slightly within the tray, mimicking the natural rotation of the knee joint. Whether that's the most successful design or not, that's another matter, but these are the two most used systems. Next, we have knee replacement options in terms of total knee replacement or partial knee replacement. So partial knee replacement is an option for when arthritis is only impacting one side of the knee joint. And partial knee replacement is also called unicompartmental knee replacement, as you can see in this picture here. It also has a similar design concept, meaning fixed bearing and mobile bearing can be seen in unicompartmental or partial knee replacement as well, as you can see here. Again, there is the smooth surface that this plastic component can slide and glide on, and we have this type which fixes in together. Obviously, this is a used implant, so the surgeon took this out and all the parts are separate now, but in reality, these two parts click in together, and that's fixed bearing. Next, we have robotic assisted total knee arthroplasty. Robotic assisted knee replacement surgery uses a robotic arm to help a surgeon replace damaged knee tissue with an artificial joint. And the robot helps the surgeon to be more precise and accurate. So how it works is a camera takes images of the knee, hip, and ankle. The images are used to create a 3D model of the joint, and the model is used to create a personalized plan for the surgery. The robot guides the saw or cutting block to perform the bone cuts, and the surgeon is in control of the robotic arm movements at all times. I've heard people referring to this as robotic knee replacement, and that sometimes bothers patients, thinking that it is more than what it actually is, which is a robotic arm that surgeon uses for accuracy. So the surgeon is always in charge. And next, we have the attractive topic of custom implants. Custom knee implants are used because they provide a more precise fit to a patient's individual knee anatomy. And the aim is to have a better function, reduce pain, faster recovery, and potentially longer implant lifespan compared to standard off-the-shelf implants, as they minimize bone removal and better replicate the natural movement of the knee joint, essentially creating a more personalized and comfortable experience for the patient. And the process of how it works for custom implants starts with scheduling a CT scan, getting your knee scanned, recreating your knee, which is done by the manufacturing company, personalizing your implant, and preparing for surgery. And that would be your custom design knee implant. Okay, just one last time. Can you give me some thumbs up or some feedback? Just a quick yes, no, this is not good. I'm finding it useful. What's your feedback for this session so that I can use your feedback to improve my next sessions. And in the meantime, as you are typing away in the comments box or sending me a message, I'm just going to remind you that if you're interested in the topic of knee replacements, please feel free to take a look at my book, We Tips on Knees and Hips, which covers all things knee replacement as well. And then this is the last section, an introduction to ankle replacement. Firstly, ankle replacement involves removing the damaged ankle joint and replacing it with a replacement joint. And it allows you to move your joint after the surgery, because the other option, as you can see on the screen to the right, is ankle fusion, which involves cleaning the worn out ankle joint and fusing the bones together with screws, plates, and bone grafts. Ankle fusion relieves pain, but it also limits your ankle's range of motion. The limited mobility can change how you walk, and that can cause wear and tear and ultimately painful arthritis in other parts of your ankle, knee, and foot. Recovery is longer with ankle fusion than ankle replacement. Patients can spend 10 to 12 weeks in a cast because the ankle joint is locked in place. And physical therapy is not part of the recovery process for ankle fusion, it is for ankle replacement. Now, ankle replacement is a newer option, and the procedure, also known as ankle arthroplasty, replaces the arthritic ankle joint with a metal and plastic prosthesis, as you can see on the screen. The recovery period is shorter than ankle fusion, typically 3 to 6 weeks in a cast, followed by physical therapy. And people regain a much wider range of motion, and most return to active lifestyles after the surgery. The components, as shown here, are tibial component at the top, because that's tibia, so tibial component goes at the top, and then polybearing, polyethylene component in the middle, right there. And then at the bottom we have talar component, and this is the dome-shaped component that goes in the bottom right here. And this particular design is called Infinity. There are 7 other designs of total ankle replacement. They also follow the concept that I introduced in knee replacements, the fixed bearing and mobile bearing concept. So if you look at these first 3, for example, you can see that there is area for the component below, plastic component, to fixate into the tibial component for all 3 designs. So that is a fixed bearing system. And then we have the mobile bearing system for the rest of them, where the 2 components can slide against each other relatively freely. And that's it for today. So yes, we went over by 3 minutes, but yes, so that's it. Thank you for your attention. If you have any questions, please leave a comment or send me a direct message. I'll get back to you as soon as possible. And yes, so this was the first time I went live on YouTube as well as LinkedIn. Previously, I did this on LinkedIn and Instagram. I see which one works best and I provide that to you. And yes, so my next session will be on shoulder, elbow, wrist, and finger joint replacement. So please keep an eye out for that, which will be early in July, likely 3rd of July. And yeah, thank you very much. Have a nice rest of your day. Bye for now.